Hi, welcome to Headline News in Breast Cancer for 2011. I'm Joyce O'Shaughnessy. I'm co-director of breast cancer research here at the Baylor-Sammons Cancer Center, Texas Oncology, and US Oncology. And today I'll discuss some new data that has recently been presented or published in breast cancer, and finish with my thoughts about where we're likely to see progress being made against breast cancer in the next few years. So today what I'm going to focus on are new developments first in the treatment of HER2-positive, triple-negative, and ER-positive breast cancer, reviewing data that is really focused on these specific subsets in breast cancer. And then I'll review additional key adjuvant data that were presented at the San Antonio Breast Cancer Symposium. And then I'll sum up with a few words about where I think the promise for future progress in breast cancer lies based on the new recent developments. So first, let's take a look at some highlights for the triple-negative breast cancer subset of patients. Now, I presented these data back in October at the ESMO conference in Europe, and over the last week or so, they've been published online in the New England Journal of Medicine, and the print publication should be out here quite soon. So these are the phase 2 data looking at the new agent Iniprib, the IV PARP inhibitor, in patients with metastatic triple-negative breast cancer. These patients had had 0 to 2 prior chemotherapy regimens for their metastatic disease, no prior treatment with gemcitabine, carboplatin, cisplatin, or PARP inhibitor. Stable brain metastases were allowed, and they had a good performance status. And 123 patients were randomized to chemotherapy alone, gemcitabine and carboplatin, both on a day 1 and day 8 regimen every 21 days, or to the same chemotherapy with IV Iniprib, given twice a week over the first 2 weeks. Patients whose disease progressed on the chemotherapy alone were allowed to cross over and continue treatment with the same chemotherapy and have the Iniprib added. And the primary objective of this trial was the clinical benefit rate. I show you here the overall survival curves. And what we see here is that the median overall survival in the gemcitabine carboplatin arm was 7.7 months compared to 12.3 months with the addition of the Iniprib, and this was statistically significant with a hazard of 0.57. In addition, the clinical benefit rate also improved substantially, with a clinical benefit rate of 32% with the chemotherapy alone, going up to 52% with the addition of the Iniprib. Now, as you recall, patients were allowed to cross over to receive the Iniprib after their disease progressed on the chemotherapy alone. So we did have a look at those patients. And it turned out that of the 60 patients randomized initially to gem-carbo, 30 of those, so about half, at disease progression crossed over to have the Iniprib added to the gem-carbo. And the median number of cycles that these patients received of the Iniprib was only 1.5 cycles. 83% of patients discontinued treatment after 1 or 2 cycles, and only 1 patient had an unconfirmed partial response. So these data show us that in patients whose breast cancer has become refractory to the gemcitabine carboplatin, that continuing the same chemotherapy and adding the Iniprib really was not of particular benefit to the patients. And this actually corroborates other studies that have shown that PARP inhibitors don't appear to be particularly active in metastatic breast cancer patients whose breast cancer is refractory to cisplatin. Now, these are very exciting data, and we look forward to the phase 3 trial of the gemcitabine carboplatin with or without Iniprib in metastatic breast cancer patients that has completed enrollment. We expect that we will have results from this very important phase 3 trial over the next several months. Another very important clinical trial that was updated at the San Antonio Breast Cancer Symposium looked at a meta-analysis of first-line bevacizumab plus chemotherapy in metastatic triple-negative breast cancer. And I had the privilege of presenting these data at the San Antonio conference. As you know, there were several first-line trials of chemotherapy with or without bevacizumab in first-line metastatic breast cancer, which showed improvement in median progression-free survival and no improvement in overall survival. Here, what we're looking at is a very large group of patients who had metastatic triple-negative breast cancer. This meta-analysis actually represents the largest reported population of patients randomized to treatment for metastatic triple-negative disease. And what we see is that the median progression-free survival went from 5.4 months with chemotherapy alone up to 8.1 months with the addition of the bevacizumab, for a hazard ratio of 0.649 that was statistically significant. In addition, the overall response rate went from 23% with chemotherapy up to 42% with the addition of bevacizumab. There was no difference in overall survival. So these data are encouraging to us because we are really in need of good therapies for patients with metastatic triple-negative breast cancer. And many times our patients don't benefit substantially from chemotherapy alone, and so it is very helpful to have agents to add to our chemotherapy that can significantly improve response rates and progression-free survival. And in my own practice, I utilize the bevacizumab and the weekly paclitaxel quite often in the first-line treatment of metastatic triple-negative breast cancer. So now, transitioning from that update specifically looking at the metastatic triple-negative population, let's look at some new data in HER2-positive breast cancer patients. And these two studies that I'll tell you about were presented orally at the San Antonio Breast Cancer Symposium. This first trial is called the NeoSphere trial, and this was a randomized phase 2 study of neoadjuvant pertuzumab plus trastuzumab. As you know, pertuzumab is an anti-HER2 monoclonal antibody that binds to the heterodimerization domain of HER2, preventing HER2 and HER3 from heterodimerizing and HER2 and HER1 from heterodimerizing. So these patients had operable or locally advanced / inflammatory HER2-positive breast cancer, and they were randomized to docetaxel and trastuzumab, about 100 patients, or docetaxel, trastuzumab, and pertuzumab, or a very interesting doublet of trastuzumab and pertuzumab without chemotherapy, and lastly, 2 docetaxel and pertuzumab. And then the patients went on to their definitive surgery, and then they had follow-up FEC chemotherapy and finished up their trastuzumab. The primary endpoint of the study was the pathologic complete response rate. Up at the top, you see the pathologic complete response rates in the breast. And we see that really the winner here, no doubt, was the triplet of docetaxel, trastuzumab, and pertuzumab with a pathologic complete response rate of 46%. The docetaxel trastuzumab PCR rate was 29%. That really wasn't too dissimilar from docetaxel pertuzumab. And what we see is that the combination of just 2 antibodies, the trastuzumab and the pertuzumab, had a pathologic complete response rate of 17%, which is quite good without any chemotherapy at all. If we look down by hormone receptor status, we see that the patients with ERPR negative HER2-positive breast cancer had higher pathologic complete response rates than did the patients with ER-positive HER2-positive breast cancer. We're getting up into pathologic complete response rates of 63% with the triplet in ER-negative patients. And so these data are really quite encouraging and give us hope that blocking the heterodimerization of HER2 and HER3 and HER2 and HER1, in addition to blocking the HER2 homodimer with trastuzumab, will further improve the pathologic complete response rate and also hopefully the disease-free survival of patients with HER2-positive breast cancer. The second very important preoperative HER2-positive trial that was presented at San Antonio is called the NeoAlto trial. And this too was in HER2-positive operable breast cancer patients. And 450 patients were randomized to one of 3 treatment arms. Patients all received weekly paclitaxel, and they received the trastuzumab as well as lapatinib in the top arm there. So that's a triplet of the weekly paclitaxel plus trastuzumab plus oral lapatinib at 1,000 milligrams a day. The second group of patients received the paclitaxel with lapatinib, and the lapatinib dose here was 1,500 milligrams daily. And then the third arm of the trial was the standard weekly paclitaxel with trastuzumab. And I know that we all know that lapatinib is an oral blocker of the HER2 tyrosine kinase. And it is felt that the lapatinib can block the heterodimerization signaling of HER2 and HER3 and also HER2 and HER1 because it blocks the internal domain of HER2, the receptor tyrosine kinase domain. And so again, the primary endpoint in this randomized trial was also pathologic complete response rate. And again, if we look up at the top now, we see that the winner for this trial again was the triplet of the taxane plus trastuzumab plus lapatinib, with a pathologic complete response rate in the breast of 51%, 42% if hormone receptor positive, 61% if hormone receptor negative. With the paclitaxel lapatinib, we see that the pathologic complete response rate in the breast was 25%, very similar to paclitaxel trastuzumab, and it was fairly similar in both the hormone receptor positive and hormone receptor negative. So again, we see here that lapatinib and trastuzumab are quite similar in combination with weekly paclitaxel as a single HER2-directed therapy preoperatively. But when we put all three together, we get a nice improvement in the pathologic complete response rate. Now, the ALTO trial has finished enrollment, and this is the Adjuvant study looking at the same question of lapatinib versus trastuzumab versus the combination. So before too many years, we'll have the answer to whether these very encouraging results in the preoperative setting really do translate into the adjuvant benefit of fewer recurrences and improved disease-free and overall survival. But very encouraging results, I think, that really hold promise for HER2-positive patients as we go forward into the future. Now, transitioning to adjuvant ER-positive directed studies that we heard about from San Antonio. We heard a nice oral presentation from Dr. Paul Goss on the MA27 trial. And this was in ER-positive early breast cancer patients who were postmenopausal. And they were randomized to 5 years of anastrozole versus 5 years of exemestane. And the mature results now, with a median follow-up of 4 years, show absolutely no difference in event-free survival. We see the curves are superimposable here. And then if we break it down into the node-negative patients on the left and the node-positive patients on the right, we see absolutely no difference between anastrozole and exemestane, saying to us that it is very reasonable to recommend either the anastrozole or the exemestane to patients based on the MA27 trial. Now, there were two oral presentations that really directed our attention to this controversy about whether we should be obtaining CYP2D6 testing in patients with early breast cancer whom we are going to treat with tamoxifen. As you know, tamoxifen is a weak anti-estrogen, and it is converted to the potent anti-estrogen endoxifen by CYP2D6. And the CYP2D6 is polymorphic. Some patients have polymorphisms that lead to a poor metabolizer status. That is, they convert very little, if any, tamoxifen to endoxifen. Some patients have two wild-type alleles of CYP2D6, and they are extensive metabolizers of tamoxifen. And then some patients are intermediate. They have one wild-type allele and one polymorphic allele, and they create intermediate levels of endoxifen, and they're called the intermediate metabolizers. And so the question is, if the patients are poor metabolizers of tamoxifen, do they benefit as much from adjuvant tamoxifen as if they were an extensive metabolizer and made a lot of endoxifen? And as you know, this has really been quite a controversial area, with some trials saying that it's very important to avoid tamoxifen in poor metabolizers, and others saying, you know, we really don't have to worry about it. So we had two data sets orally presented at San Antonio that looked more closely at this question. And the first was from the ATAC trial that looked at a comparison of anastrozole versus tamoxifen in early stage ER-positive postmenopausal women. And so here what we're looking at is the tamoxifen alone arm. And we're seeing on the left the recurrence rate over time looked at by metabolizer status on the patients. And what we see is that there is really no difference at all in the risk of recurrence for the patients taking tamoxifen, whether they were a poor metabolizer, an intermediate metabolizer, or an extensive metabolizer. It really made no difference at all in the ATAC trial. The other data set we had a look at was the Big 198 trial. This too looked at outcome on tamoxifen by CYP2D6 metabolizer status. And as you see here as well, no difference whatsoever in outcome on tamoxifen, whether patients were poor, intermediate, or extensive metabolizer of tamoxifen. And so these data really were reassuring to us in our practice that patients will benefit from tamoxifen regardless of metabolizer status. The ATAC trial did take into account whether or not patients were receiving the strong SSRI inhibitors of CYP2D6, but the Big 198 was not able to look at this variable. So I think what this told me is that there's really no role for CYP2D6 testing in our patients before we decide whether or not to recommend tamoxifen adjuvant therapy to them. However, it probably still is prudent to avoid these strong SSRI inhibitors of CYP2D6 as per the ASCO guidelines. Now, there were a couple of other important data sets specifically looking at estrogen receptor positive breast cancer patients now in the metastatic setting presented at San Antonio. And Professor Robertson gave us an update on the first trial. This was postmenopausal ER-positive patients receiving first-line treatment for their metastatic disease. And they were randomized to standard anastrozole or to the higher dose fulvestrant, 500 milligrams day 1, day 14, day 28, and then every month thereafter, the newly approved FDA regimen of the higher dose fulvestrant. Now, the primary endpoint was the clinical benefit rate, and it had been previously published that indeed the clinical benefit rate was slightly higher with the fulvestrant compared to the anastrozole, but not markedly so. So what we saw at San Antonio was extremely interesting with regard to the updated analysis on time to progression. And what we see here is that there was a substantial improvement in time to progression in favor of the fulvestrant. We see here 23 months of median time to progression with the fulvestrant compared to about 13 months with the anastrozole. That was a 10-month improvement in median time to progression in favor of the fulvestrant for a hazard ratio of 0.64 and a p-value of 0.01. And I will tell you that these data have changed my practice. Now when patients present with their first recurrence of ER-positive metastatic breast cancer, I'm recommending the higher dose fulvestrant schedule to them instead of an aromatase inhibitor. So these data, I think, are very important for our practice. But my favorite data set of all from San Antonio was the TAMRAD trial presented here. This was an investigator-initiated trial that looked at ER-positive metastatic breast cancer patients whose breast cancer had progressed through an aromatase inhibitor. And the primary endpoint was the clinical benefit rate. And just over 110 patients were randomized to standard tamoxifen versus tamoxifen with the mTOR inhibitor everolimus, 10 milligrams a day. And patients were stratified for whether they had primary refractory disease to an aromatase inhibitor. That is, they really hadn't benefited from an aromatase inhibitor in the metastatic setting. You know, they didn't have 6 months of benefit in the metastatic setting, or they had actually relapsed on adjuvant aromatase inhibitor therapy as opposed to having stopped it after their 5 years and then have been off of it for a while in the adjuvant setting and then recurred. And so these patients, again, tamoxifen with or without the mTOR inhibitor everolimus. And what was shown here up at the top, the clinical benefit rate was 42% with the tamoxifen versus 61% with the addition of the everolimus, and that was statistically significant. Overall survival also favored the addition of the everolimus with a hazard ratio of 0.32 that was also significant. Time to progression also favored the addition of the everolimus, and we see here the hazard ratio of 0.53 and median time to progression going from 4.5 months with tamoxifen up to 8.6 months with the addition of the everolimus, and that was significant. But I think what was so interesting in this trial is if we look at patients whose breast cancer was primary resistant to the aromatase inhibitor given previously, there was a trend towards improvement in time to progression, but not significant. But in patients whose breast cancer had benefited originally from the aromatase inhibitor and then who developed resistance to the aromatase inhibitor and then went on to tamoxifen with or without everolimus, we see a very large improvement in time to progression from 5 months up to 17 months with a hazard ratio of 0.38. So this is a very large improvement, showing us that the PI3 kinase pathway is very much operative in patients whose breast cancers develop resistance to anastrozole or other aromatase inhibitors. Now, these are small numbers of patients when we're getting down into these subsets, but a very, very interesting signal. And we await the results of the Bolero-2 trial, where patients who had been previously treated with an aromatase inhibitor were randomized to exemestane alone versus exemestane plus everolimus, a very large phase 3 trial. So hopefully these interesting data from the TAMRAD trial will be borne out in the larger Bolero-2 trial. So now what we're going to do is we're going to transition away from the studies at San Antonio that focused on specific breast cancer subsets, and we'll look at some data from large adjuvant trials that enrolled several different subtypes of breast cancer patients onto these large adjuvant trials. And the first study I'll discuss is the long-awaited Azure trial. And in the Azure trial, patients with early-stage breast cancer who had stage 2 or stage 3 disease were randomized to receive standard therapy, whether it be chemotherapy followed by endocrine therapy, chemotherapy alone, or just endocrine therapy, with or without zoledronic acid. And the zoledronic acid was given for several doses monthly, several more doses every 3 months, and then finished up 5 years with an every 6 monthly schedule. And versus the standard therapy, and patients could be premenopausal or postmenopausal. And disappointingly, what we saw was that there was no difference in disease-free survival or invasive disease-free survival, as we see here in these curves. And this is disease-free survival we're looking at here. Now, in a pre-planned analysis of patients according to menopausal status, what we see on the left is in pre- and perimenopausal patients, there was no benefit from the addition of the zoledronic acid with regard to survival. But in patients who were definitely postmenopausal, who were 5 years or more away from their last menstrual period, or who were over the age of 60, we see a very interesting finding of improvement in overall survival with the addition of the zoledronic acid, with a hazard ratio of 0.7 and a significant p-value. So this is a very important subset and an important finding in a subset analysis, and I think it does await further evaluation in a prospective trial, and there are several other trials going on looking at bisphosphonates, either oral bisphosphonates or the IV zoledronic acid in the adjuvant setting. So no overall benefit in the overall treated population, but a very interesting signal that requires further follow-up and study in postmenopausal patients. Another important adjuvant trial that was presented by Dr. Larry Schulman was the CALGB 40101 trial. This was a study that allowed entry of women with node negative to up to 3 positive axillary lymph nodes, pre or postmenopausal patients. However, 94% of the patients were node negative. And the question being asked in this trial was actually whether 6 cycles or 4 cycles of AC or paclitaxel would be beneficial to patients with early breast cancer. There's a second question, as you see, comparing AC to paclitaxel. The Data Safety Monitoring Committee released the data on the 4 cycles versus 6 cycles, putting the data together for the AC and the paclitaxel cohorts in this 2x2 factorial design. The data comparing AC and paclitaxel directly are not yet mature and available to us. And what we see here, looking at all patients, is no difference in relapse-free survival or overall survival comparing 6 cycles to 4 cycles of either AC or paclitaxel in this node-negative population. If we ask the question, well, what about the patients who have more aggressive, virulent breast cancer, the estrogen receptor negative patients, again, we see no difference at all in relapse-free or overall survival. And if anything, the data are favoring patients who received 4 cycles of therapy. As you would imagine, the toxicity was more in patients who received 6 cycles of therapy, with more congestive heart failure and more secondary AML or MDS in patients receiving 6 cycles of AC. So these data are pretty clear to me that we would not want to be giving 6 cycles of AC or 6 cycles of paclitaxel to patients with node-negative breast cancer, that there's no benefit to going beyond 4 cycles of paclitaxel or AC. And we await the results of the head-to-head comparison of AC versus paclitaxel in this node-negative population. And then there were 2 oral presentations focusing on the role of capecitabine, the oral 5-FU prodrug, in patients with high-risk early breast cancer. And the first trial was an update of the FIN-XX trial presented by Professor Joyce. As you may recall, the 3-year follow-up data of the FIN-XX were published in the Lancet Oncology about a year ago. And now what we saw at San Antonio is the 5-year update of the FIN-XX trial. In this trial, 1,500 women with node-positive or high-risk node-negative breast cancer were randomized to chemotherapy with or without capecitabine. High-risk node-negative here was defined as progesterone receptor negative breast cancer. The standard arm is shown below with docetaxel for 3 cycles at 80 milligrams per meter squared, followed by 3 cycles of CEF. The investigational arm was docetaxel at 60 milligrams per meter squared with capecitabine, and this was 900 milligrams per meter squared BID, 14 days on, 7 days off for 3 cycles, followed by the cyclophosphamide, epirubicin, and 3 more cycles of the capecitabine. And the primary endpoint was recurrence-free survival. And shown here is the actual schema that I've just gone over with you. Recurrence-free survival was 86.6% with the capecitabine arm versus 84.1% with the standard arm, for a hazard ratio of 0.79 and a p-value of 0.087. So unfortunately, recurrence-free survival, though it was significantly positive at 3 years, was no longer significantly positive at the 5-year mark. Dr. Joyce did an exploratory analysis of the biologic subtypes of breast cancer, and as you see, the only subgroup that really had substantial benefit from the addition of capecitabine was the triple-negative patients down in the bottom right. Here, the hazard ratio for relapse-free survival was 0.48, and that was statistically significant, and that's a rather large improvement in the triple-negative population, and this is quite encouraging, although it's an exploratory analysis. The second adjuvant capecitabine study I actually gave an oral presentation for at San Antonio, and this is the US Oncology Adjuvant trial of 01062. In this trial, patients with high-risk node-negative or node-positive breast cancer were randomized to 4 cycles of standard AC, followed by 4 cycles of docetaxel at 100 milligrams per meter squared, versus the same AC for 4 cycles, followed by a lower dose of docetaxel, 75 milligrams per meter squared, in combination with capecitabine, 825 milligrams per meter squared, BID, 14 days on, followed by 7 days off for 4 cycles. 2,610 patients were randomized on this trial, and we present the mature update at 5 years median follow-up with the primary endpoint disease-free survival. Unfortunately, because there turned out to be fewer events as the years went on in follow-up of this large trial, the overall power of this trial, which was initially planned to be 80% power, turned out only to be 57%, because of the actual good news for patients that there were far fewer recurrences on this trial than had been anticipated when the trial was first designed back in 2000. What we see here with regard to disease-free survival is that there is a slight trend towards improvement in disease-free survival in favor of the capecitabine arm with a hazard ratio of 0.84, but this is not statistically significant, so the trial did not meet its primary endpoint of disease-free survival. Overall survival was a secondary endpoint, and we see here a hazard of 0.68 with a p-value of 0.011. However, we must be very cautious in interpreting these survival data because of the low number of events in this trial. We did a retrospective exploratory analysis of disease-free survival by Ki-67, and we did this because this trial allowed patients with indolent ER-positive breast cancer onto the trial, and now we know, 10 years later, from when the study was first designed, that ER-positive patients with indolent disease may not benefit very much from chemotherapy and are really not the ideal patient population to be asking this important chemotherapy question in. So we wanted to look at Ki-67 as a surrogate for virulence of disease. Now we're looking here at locally performed Ki-67, and only 40% of patients had Ki-67s performed in the local laboratory. If we look first at all patients, we see that there were very few recurrence events in patients who had Ki-67 under 10%, only 9 and 12 patients in the ACT versus ACXT arms. In patients who had Ki-67s of 10% or greater, there were greater numbers of recurrent events, and we see a hazard ratio of 0.7 that was significant, although of course these are exploratory. If we look specifically in ER-positive patients who are HER2 negative, who we don't think chemotherapy really benefits greatly if they have very indolent breast cancer, we see single-digit numbers of recurrences, 6 and 9, in patients with Ki-67s under 10%, really confirming that these patients really should not be enrolled on clinical trials where the question is recurrence over the first 5 years. However, for patients who had a Ki-67 of 10% or greater in the ER-positive, HER2-negative population, we see greater numbers of recurrences, and we see that the addition of capecitabine led to an improvement in disease-free survival with a hazard ratio of 0.66, but the confidence intervals did cross 1 in this small retrospective exploratory analysis. However, I think this raises up a very important hypothesis that the capecitabine may be improving outcome in patients with more virulent breast cancer, such as the triple negative and such as the more highly proliferative ER-positive population. And then to finish up, I will finish with a chemotherapy study for metastatic breast cancer patients because Eribulin has become an important new option for us in our standard care of patients with metastatic breast cancer. As you know, the EMBRACE trial randomized 762 patients with metastatic breast cancer to receive the new microtubule-directed agent Eribulin at 1.4 milligrams per meter squared, given over 2 to 5 minutes IV on day 1 and 8 on a 21-day schedule, versus treatment of physician's choice, and this turned out to be largely a cytotoxic agent, mostly gemcitabine, capecitabine, vinorelbine, taxane, or an anthracycline in a 2-to-1 randomization. The primary endpoint was overall survival. Patients that had a prior anthracycline and taxane and were required to have had between 2 and 5 prior cytotoxic regimens for metastatic breast cancer. We've seen these data previously presented, and in fact, there was an overall survival advantage in favor of the Eribulin, and this led to FDA approval of Eribulin, which is now available to us in our practices. What we saw updated at San Antonio were the response rate data and the overall survival data. And I thought it was interesting to look at the objective response rates and the clinical benefit rates by breast cancer biologic subtype. Up at the top there, you see the treatment of physician's choice had a very low response rate of about 3% In the ER-positive population, that went up to about 15%. With the Eribulin, clinical benefit rate, including patients who had stable disease for 6 months or longer, was 15% in treatment of physician's choice versus 25% with Eribulin. If we look down at the bottom at the triple-negative population, we see that response rates were indeed quite low, both with treatment of physician's choice as well as with Eribulin in the triple-negative population, and were also similar for the clinical benefit rate of about 10%. However, what's interesting is if you look at the updated overall survival, the overall treated population is up top with a significant overall survival, and it was about 10 months with treatment of physician's choice versus 13 months with the Eribulin. However, in all of the biologic subsets, whether it be the triple negative, whether it be the ER-positive patients, the trend there was towards improved survival in favor of the Eribulin. Of course, some of the confidence intervals cross 1 because these are smaller subsets. So even though the response rates with the triple negative population with both treatment of physician's choice and Eribulin were quite low, still overall survival favored the Eribulin treatment. The other thing I thought was interesting and perhaps of practical importance for us in our practice is breaking down patients as to whether they had had 3 or fewer prior chemotherapy regimens versus more than 3 prior chemotherapy regimens. You see, the majority of patients had had 3 or fewer prior chemotherapy regimens. We see that there was a survival advantage in favor of the Eribulin, 10.7 months versus 13.3 months, with a hazard of 0.774 that was statistically significant in patients who were less heavily pretreated. In the more heavily pretreated population, there really wasn't much of a difference there in overall survival. So it suggests that we might consider using this important regimen that does favorably impact overall survival a little bit earlier in the course of metastatic disease. So I've taken you on a little bit of a whirlwind tour of some of the updated data with regard to early stage and metastatic breast cancer with updates from the San Antonio and ESMO conferences. And what I'd like to say in conclusion is that the phase 2 data of eniprib with gemcitabine carboplatin in metastatic triple-negative breast cancer patients are indeed very promising. We await the phase 3 eniprib data, and if they're positive, no doubt quickly will follow an adjuvant triple-negative breast cancer trial, and this could be very important for our triple-negative breast cancer patients in the metastatic setting. Bevacizumab also looks very good, first-line metastatic triple-negative breast cancer, and we await the results of the now enrolled Beatrice trial of adjuvant chemotherapy with or without adjuvant bevacizumab, specifically in triple-negative breast cancer patients. HER2-positive disease, there continues to be substantial promise for our patients with HER2-positive disease. We saw exciting results from the NEO-ALTO with preoperative lapatinib and from the NEOSPHERE trial with preoperative pertuzumab. We await the results of the adjuvant ALTO trial, bringing adjuvant lapatinib in with adjuvant trastuzumab and chemotherapy to HER2-positive patients, and we await the results of the adjuvant BETH trial of chemotherapy with or without bevacizumab in HER2-positive patients. Another promising area that we saw early data on at San Antonio was a combination of the immunoconjugate TDM1, which is trastuzumab, hooked up to the vinca alkaloid emtansine. Very, very promising agent in combination with pertuzumab. Looks very good in metastatic breast cancer patients, and I think we can see our next generation HER2-positive adjuvant trial shaping up with a combination of TDM1 and pertuzumab. In ER-positive disease, I saw that the first-line higher-dose fulvestrant versus anastrozole, the first trial, changed my practice pattern towards first-line fulvestrant at the higher dose now approved by the FDA. And I was very interested in the TAMRAD results, bringing the mTOR inhibitor everolimus in combination with tamoxifen to patients in metastatic breast cancer who had benefited originally from aromatase inhibitor therapy and then now who were resistant to aromatase inhibitors. And we certainly await the results of the BOLERO-2, which hopefully will confirm the TAMRAD data with exemestane, with or without everolimus. If these are positive, perhaps we'll want to block that PI3 kinase pathway in an adjuvant trial in patients with ER-positive breast cancer. Regarding the role of capecitabine in early-stage breast cancer, unfortunately, both the PHYNX-X and the US Oncology trial did not meet their primary endpoints, and so these studies will not change the overall standard of care in the adjuvant setting. However, looking at specific patient populations, the highly proliferative patients, the triple-negative patients, certainly central pathology review of ER and Ki-67 is warranted and is ongoing in both the PHYNX-X and the US Oncology trials, and we will put our data together and do meta-analysis in triple-negative patients and in the highly proliferative ER-positive patients to see whether or not specific subsets of patients may benefit from adjuvant capecitabine. And with regard to adjuvant capecitabine, US Oncology will conduct an adjuvant safety pilot study of combined Eribulin plus capecitabine in ER-positive early-stage breast cancer patients to determine the safety of this regimen with careful attention to alopecia rates, because this could be a very interesting, effective combination to take forward into the early treatment of ER-positive, lower-risk population. So I hope this has been a helpful review for you of the new data that has come out recently in breast cancer, both in early stage and metastatic patients. I think it's quite clear that we're making good promise against patients with breast cancer, and we eagerly await the results of metastatic and adjuvant trials that have been completed. I thank you very much for your attention and for joining in. Bye-bye.